Hi, everyone, and welcome to What's Up, Doc. It is our weekly broadcast where we provide an opportunity for patients to ask a physician their questions, their burning questions live. Today, we have a very special guest. We have Dr. Kumar Madassery. He is an interventional radiologist at Rush Hospital in Chicago. Very lucky to have you. Busy, busy day for you out there in Chicago. Lots of cases today. You're still at the hospital, still seeing patients. Thank you so much for taking the time.
No, thanks for having me. I'm sorry I'm late, but this is always a pleasure to connect, and I love what you guys are doing and what you've done. So, all I can do is be available.
Oh, no, we appreciate it. Any highlight from today or any lessons that are worth sharing that were learned today, either by you
Yeah,
or by a patient?
interesting. So, my first case today was a patient who I did what's called a deep vein arterialization, a DVA. On this patient, I did this about 6.5 weeks ago on a patient who was told from another facility that there's no options left and that he has to wait for a major amputation. And, sometimes that's reality, but some of us are doing this connection between an artery and the vein from the inside and hoping that if it survives and it can last a month or two, that we start waking up and forming new vessels in the foot. So I did that procedure 6.5 weeks ago, and I saw him in clinic 2 weeks ago. He was jumping for joy, saying his rest pain's gone, but we're still kind of watching and waiting to see if his blood flow gets better. He goes, also, I'm going to Boston for a week. I said, okay, I have some friends out there. If something happens, let's keep a close eye on you. And I said, I am worried about checking your DVA to make sure everything's okay. I want to bring you back in. So he comes back from Boston, still feeling great. I did the angio today, and the DVA is down. Turns out he was feeling some weird shoulder pains, so he stopped his Plavix. He thought his Plavix was causing some shoulder pain, which, who know, everybody's reactions can be different. And he didn't think much of it. And the thing with the deep vein arterialization is if it shuts down, you won't feel the symptoms that you do when your normal artery shut down. So sometimes you don't know that it shut down. So he didn't know. And luckily I was able to reopen it. But what I noticed was, even though it's only been 6 weeks, he already had awakening of arteries in his foot. So he is on the road. So luckily we were able to open it back up, and I'm going to hope that another few weeks he can get his toe amputation and try to avoid the major one that he was guaranteed. So we don't know. This is still a shot with a lot of prayers. But the key was, he says, I feel so bad. I should have called when I had this shoulder pain and asked what I should do instead of just stopping the medic. I didn't think about it. Even though we counseled, we talked about it. It's hard when you're dealing with so many things. I totally get it. So that was a good learning lesson this morning, is to keep telling them all the different things. Call us before you stop something. That was case number one this morning.
Right, isn't that interesting where you would think it would be Captain Obvious in a sense that you should always continue to take your medication unless otherwise indicated by your physician, and if you think you are having a reaction to that particular medication, to always, always, always get on the phone with the doctor or the office and say, "Hey, I'm experiencing these symptoms. I don't know if they're related. Can we have a conversation about this?" So
He,
important.
he's been, before we did the DVA, he was sitting on a recliner sleeping most days because of pain and his wounds. And so the last 3-4 weeks he's been sleeping in a bed comfortably. And I think sometimes your mind thinks things are great, and you start focusing on normal life again. He goes, oh, I got some shoulder pain, it must be the new med, not remembering we had a lot of conversations about how important it is to stay on that right now. And even with the medication, could he have had a problem and shut down? Absolutely. So it's just, we can only optimize what we can and try to fight for what we can. So it's, knock on wood, the first one today was a recovery for now. So we'll still seeing how that one will go.
Why it's so important to stay on particularly an antiplatelet therapy such as Plavix, or if the doctor puts you on anticoagulants such as Xarelto or Eliquis or Coumadin, Warfarin, whatever it might be, it's important to stay on it. There's a reason why, and especially I'm going to let you. I was going to explain because why doctors put you on Plavix afterwards, but since you're here, you're the doctor. Go ahead and explain, and take the podium on that one.
Yeah, so
Why
most
do you give Plavix?
so the reason why, the standard recommendation based on data is to use what we call dual antiplatelet. What that means is, antiplatelet means trying to block those things that form your scabs. those little platelets that clot together. So antiplatelet means trying to give medication that prevents you from forming clot. So that's antiplatelet. Aspirin is one of an antiplatelet agent. And then Plavix, it's got a generic name called clopidogrel because now the patent has run out, so they can't charge you exorbitant money. Now it's generic also. That's another antiplatelet agent. So the standard therapy is dual, meaning two antiplatelet therapy for patients with peripheral arterial disease because you are at a higher risk of clotting your arteries, especially if you've had any interventions or surgeries. Because now, once we touch your vessels with a wire, a balloon, a surgery, a bypass, that inflammation that your body responds with sometimes causes you to close down faster. So we put you on antiplatelet therapy to try to prevent your blood from clotting. Now, some people are put on anticoagulation. That's a little different. Anticoagulation, such as Coumadin, Xarelto, Eliquis, but all these other things, they're a different form. It's a different term, but what they do is they work with your cascade of your body that causes clotting. It's a different mechanism than Plavix and aspirin. So some people will be put on Coumadin or other agents that thin the blood more. So that's that. So historically, patients with PAD, we put them on aspirin, baby aspirin, which is 81, plus Plavix. Now, the data most recently in the last 3 years from cardiology studies and literature of like 10,000 patients, they found that for patients with PAD and also risk factors for heart attacks and strokes, they actually did better with baby aspirin and Xarelto, which is the other agent I was talking about. That's from studies called Compass and Voyager. They're very large patient populations. And what they found was by using Xarelto and aspirin for these patients, they had less chances of having a major amputation, heart attack, or stroke. So a lot of us over the last year or two have been trying to transition or change patients onto Xarelto and aspirin. The one issue is that there's a cost problem sometimes for a lot of patients based on insurance and out of pocket. So that's still one of the battles we face, even though the data says it's good. Unfortunately, insurance and medicine doesn't catch up to data. Janssen, who makes Xarelto, does have a lot of programs to give you discounts and packets and all that stuff. I don't know how well it works for everybody. They make it sound like they can work with anybody, but I think we all know in reality that's not how things work. So currently, if you're a new patient, we'll try to start you on the Xarelto and aspirin. But if you're already on therapy and we can't get you Xarelto, it's still data shows it's good. It's just that if we can switch you, we try to use what the best data is. I know it's a long-winded answer. And then also one thing I'll tell you additionally, Plavix, if we put a stent in you, Plavix still has shown to have better results to help that stent incorporate into your blood vessel within that first month. So in a patient, when I put a stent, I'll try to put them on Plavix for a month and then switch them to Xarelto or stay on the Plavix. So there's a lot of nuances, but there's a reason why we're putting you on any of this because we want to prevent your legs from clotting. That's basically the point. It's a little different than the blood clots you get in your veins called DVT. This is arterial disease that narrows and narrows and narrows. And then when it narrows, it's like the pipes in your house from the water tower to your faucet. If the pipes have debris in there or crud, your faucet's not going to run fast. If at some point that pipe blocks completely, the faucet's not going to run at all. So we're trying to prevent the faucet from not getting any blood flow, which is your toes.
Nancy has a question. Nancy, go ahead and unmute and ask Dr. Madassery your question.
Okay. And thank you. And last year, from January through March, I had to go off Xarelto because of the cost of it. It would have cost me hundreds of dollars, and I'm on Social Security. Is there any other drug that's available, like Eliquis or anything else? I am on aspirin and Plavix and Xarelto. I'm on all three. And I have a stent in my left.
Sorry, good.
I'm good.
Oh, so honestly, do you know why did they put you on triple therapy? Because the data did not show any benefit by being on all three. We sometimes do that in patients who failed while on two. But was it because you failed on some treatment that they put you on all three?
No, my vascular surgeon, he wanted me to go on Xarelto, and I was on Plavix and aspirin. So I went off it for 3 months, but I was leery because, I keep thinking, well, am I going to have a stroke or what's going to happen? So as Xarelto, Janssen has a program that starts April 1st to help financial aid, and it gets the cost down to $80 a month. So as soon as that came up, I went right back on it. But for 3 months, I had to go off. I wish
Yeah.
they would more.
We struggle with this because we'll say, hey, we tell our patients, here's the best data. We say, start taking this, and then they find out they're not covered, they can't afford it. It's like, well, how are we supposed to deliver the proper care when the companies and insurance doesn't provide the ability to? And then you're like, well, now I'm not getting the best care for myself. It's very
Yeah.
frustrating. But being off it for 3 months, if you're okay right now, congrats, you're okay, and you were on dual antiplatelet already. You were on Plavix and aspirin.
Yes.
If you fail on aspirin and Plavix, sometimes we'll switch to Eliquis. It's a different form of kind of what Xarelto does. It's just that we don't have the data saying that Eliquis does the same.
Okay.
The Eliquis and Xarelto data comes from the DVT literature when they compare those two, the blood clots in your veins.
Mhm.
But we can technically apply that to you. So if you were failing on aspirin Plavix, then I wouldn't have a problem switching to either Brilinta, which is another medication, or
Mhm.
Eliquis. So
Okay.
if you're doing okay, you're still on the Plavix and aspirin, which is what we've used for 10, 15 years.
Okay.
It's just that we have newer data saying maybe there's a benefit to using Xarelto.
I'm trying hard to get, because Janssen told me that, well, if you order a 90-day supply in December, that will get you through. So I'm trying to work with them and work through this, but it's like a juggling act because it's so expensive with all these drugs, and I'm on quite a few drugs. So
Sometimes, Kim, I wonder if Janssen will be willing to come help you with distribute. I'm sure you worked with them, but they always are looking at how they can outreach to patients. They have always trying to reach out meetings and stuff.
We're actually a partner with we're a partner with their Save Legs Change Live program. And so when they go out there and they do the testing sites across the US, every single patient who ends up with a positive result ends up with our number for the Leg Saver hotline to be able to call in and get support and get direction on next steps. So
Good
call.
But Nancy, at least you're on the double therapy, which we've been doing for a decade and a half. So you're not being treated. And a lot of patients who have PAD never were on anything, and they don't progress. So we do it because we think it'll prevent some things.
Yeah, I have a good vascular surgeon. I go to Dr. Antizana, and but I have coronary artery, had a heart attack, I have diabetes, and I have peripheral artery, but I'm fighting hard. So
Good for you.
yeah, but it's a struggle with all of the medications that I'm on and trying to get financial aid because I'm on Repatha, which is very expensive. So, it's hard when you're on Social Security. So
yeah.
anyhow.
And I think there's so many people that can relate to that. Thank you so much, Nancy. We have questions coming in from Alan, and we have Heinz. But Alan Schunart, go ahead and ask your question first, and then we'll get to Alan Potts, and then we'll follow by Heinz.
Hey,
Doc.
We're having trouble hearing you, Alan.
Whoops. I said, hey, Doc, when's my next appointment? Still can't hear me?
check your mic chart. Check.
I just want to say hello. I'm doing fine.
Good to see you, Alan. Check your mic chart. I'll tell Jessica to call you.
Yep. See ya.
So he just wanted to say hello. So Alan, go ahead and ask your question of Dr. Kumar Madassery.
Thank you. Doctor, I was on a baby aspirin and a drug called pentoxifylline.
Pentoxifylline, yeah.
Pentoxifylline, okay.
Yeah.
About 4 weeks ago, I came down with anemia. I had anemia last September, and it came back on me 4 weeks ago. And my doctor told me to stop taking the baby aspirin until I get blood work that would show my hemoglobin count and red blood cell count would be, back to normal.
Right.
Is there anything else I could take in place of the aspirin? Or do I just live without it for a couple months, 2 or 3 months?
Yeah, it's a tough call. We always say like the only reason why we want to stop any of those things if you have a bleeding problem, that's or a severe allergy. That's about the only 2 times we ever say to hold or stop a medication. Unfortunately, if you have to stop aspirin, all the others also will potentially cause bleeding. Sometimes the theory is that aspirin, even if it's a baby dose, may cause more bleeding than a Plavix or a Xarelto. So
Okay.
sometimes in some patients, when I have them on both medications, I'll have them stop the aspirin first, keep them on the Plavix or the Xarelto,
Yeah.
and then if they still have problems, I have to stop both until we get a solution, if we can.
Okay.
So you're on pentoxifylline, which is a medication called Pletal. That's the goal of that one, if they've explained it to you, is to try to help your blood vessels kind of juice up on their own.
Yeah. They
so-
said it would make the cells more flexible.
Yeah, so it's not a blood thinner, even though some people stop it for procedures. So it's not typically one that should cause bleeding. That's why they probably didn't tell you to stop that one.
Yeah.
But the aspirin, if you stop it, if you were on both, I would stop the aspirin, keep you on the Plavix. So
Yeah.
if they can't find a solution, you can always ask, is it okay if I at least get on Plavix or something else to protect you?
Okay. It does lead me to another question. 2 weeks ago, I got diagnosed with acute urticaria. So I had a full body allergic response.
Uh-huh.
Is it possible that some of these drugs that I'm taking, like I've been taking this pentoxifylline for 3 or 4 months, and other medications, some I've taken for years. Is it possible that all of a sudden I've developed an allergy to one of these drugs? And
Yeah, unfortunately, you can get delayed allergies to medications.
Yeah.
It's always possible. The best
Yeah.
people for that, what they do is your doctors typically stop one by one, and then restart one by one. And sometimes they send you to an allergy specialist
Yeah.
where they can test certain things. They can test for other environmental, clothing, food allergies.
Yeah.
Unfortunately, when you're taking, like, let's say 20 pills, it's a little hard to tell
Yeah.
which one, but usually we'll say stop the most recent one.
Yeah.
And see if that makes a difference.
Yeah. Okay. I
Thank
won't stop.
you,
I won't
Alan.
stop anything until I talk to my doctor.
Yes, please,
See?
please, please, please.
The
talk to
lessons
your
are
doctor.
already
Please talk
learned.
to your doctor first, too.
Thank you.
Heinz, thank you, Alan. Heinz, go ahead and unmute and ask your question for Dr. Kumar Madassery.
Hi, Doc. Let's
Hi.
talk about walking. When you walk, you're told that if you have pad, that the walking will help build collaterals. And my curiosity question is, okay, let's say you have a blockage in your leg. At what point does it start using your collateral arteries? I mean, is it 100% occluded, or at what certain
No.
point does it start using those other arteries?
So what happens is, typically in a situation where you have arterial disease and your arteries start narrowing, as it narrows beyond about 50%, about half the caliber of your blood vessel, your other branches start trying to take on more of the demand. So you start forming collaterals typically when you have at least 50% stenosis. The problem when it's completely occluded is, when did it get completely occluded? Was it a gradual process or was it sudden? Typically, if it's a gradual process, you start getting bigger and bigger collaterals as the narrowing increases. And then your collaterals get so big that even if it's shut down, you may not have had an acute emergency. If you don't have collaterals that have been forming for a while and then you shut down, that's when you sometimes have severe excruciating pain, cold leg, can't walk, lose sensation. So it's typically about 50% narrowing, where your collaterals, your branches that are already there, sometimes start getting bigger and bigger to compensate for your narrowing. So the more you walk, the more you're forcing either the narrow vessel that you have originally or the collaterals to keep getting bigger and bigger. So it's kind of a gradual process. If it happens suddenly, that's when we get the most amount of concern on how to save your leg right away in the ER.
Okay, with that, so you're walking, you build your collaterals. Does an ABI after, like, let's say you're walking normal without pain, would an ABI after 3 months show that you have PAD, or do you need other tests?
So an ABI can still show you if you get a full ABI. So ABIs can be done a couple different ways. It can be just where they check your arms and your feet. or you get the ABIs that look down your leg at different levels. And you can see the wave changes and the pressure changes as you go. So you can see the difference. What we care about at the end is if it's a reliable ABI, has it improved from your baseline? Or if you don't have a baseline, where are you at right now? Regardless of the numbers, we should treat you based on your symptoms.
Yeah,
When you
but if
start
you have
taking,
no pain, how would, I mean, would it, that's
Yeah.
why I asked, if you have no pain anymore because you walk yourself to a good point with collaterals, you know, how can a test determine that an ABI test determine that you have a real problem in your main artery?
so again, your ABI could be less than perfect and tell us that there's disease, but your symptoms aren't there. So we wouldn't focus on, we wouldn't try to do anything anyway, but we'd monitor you. If something was suspicious on an ABI, we would get a duplex to look at the arteries themselves.
Okay.
So if you're not in pain, again, no one should be touching you unless you have a wound or something else, because everything you do once you touch you starts the cycle. We try to treat something that's affecting your life without doing something unnatural to your body. That should be the goal. That doesn't happen all the time and everywhere, but if it's not affecting your life and you're able to fight through it, and what Kim teaches you guys and fight and promotes for you guys is walk, 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 because the best thing you can do is walk away from the hospital. That's kind of the best thing. Like walk towards it, but if you just walk away. Because once you get in and once you have a procedure, you're starting the clock. No matter
Yep.
who does what, surgery or endo or minimally invasive, or we're just going to do a little oil change touch up. It's not a Tesla, and I don't know if those are good either, but
So the question that a lot of people always ask, and I think it's kind of what Heinz, you can correct me if I'm wrong, I think you're getting to, is does the ABI actually show improvement in the numbers with collateral growth?
yes.
Right.
So, but to know that, you would have to have kind of a baseline when you're having problems in the beginning. So if you have claudication, typically your ABI, if it's a trustable ABI, because if you have calcium, sometimes we can't rely on that. But if you have a trustable ABI, let's say, and I always tell patients, think of it as a percentage. If your ABI says 0.8, think of that as 80%, which is like a B when you're in elementary school. So you have 80% of blood flow from your heart reaching your foot. And then let's say you work through it, you do your medications, you work on your diet, your diabetes, and you're walking. We see patients that get to 0.9, 90%. Now you have an A. Is it going to be 100? Maybe. But again, the key is, did it improve without us touching you? And even if it's completely blocked at one segment, you can form good collaterals, juicy, big, or large collaterals that will bring your ABI up. Now, will it be perfect? No, but the number doesn't matter as much as how far are you walking? How's your pain? Are you carrying out your job, your life, your self-care? That's what matters the most.
Okay. Thanks. I'm going to make a comment and then I'll let you go. I was on aspirin, baby aspirin, Plavix, and the aspirin tore up my stomach. So they put me on Eliquis and Plavix just as an example for the bleeding part. So anyway, thanks for all your help.
You're very welcome. Keep walking.
Thanks.
Okay, we have a question coming in from Linda, which I think you've kind of answered indirectly here. She said she was diagnosed last March. She's on a good diet. She walks 2 miles a day. She doesn't smoke. She does take Plavix. It's in her right leg. She cannot walk further now without pain. And she even is starting to have some rest pain. And when she goes to the grocery store, it's limiting. She wants to know if everyone pretty much with those symptoms end up with a stent. She's 78 years old and she's hoping not.
No, so everyone doesn't need a stent. Everyone doesn't need a bypass. Some people can get away with the balloon and some people get away without any procedure at all. So it really depends on how bad is it, what are your arteries looking like when you do either a CT scan to see the arteries or an angiogram. Our goal typically for most of us who do this at kind of a high level is try to avoid a stent unless you have an area that is going to come back down right away. What you have to remember is anytime you have a narrowing or a blockage, we're going in with wires and balloons. And what we're doing is we're cracking open that vessel. But just think about that pipes in the house I told you about. You can have a 100-year-old house. You clear out some pipes with a roto-rooter, you call your plumber. I can guarantee you at some point the pipe's going to clog up again. Same thing here. We go in there, we crack a balloon. We're not replacing your artery. We're trying to recreate a channel. But now we irritated your vessel. It causes inflammation. That narrowing is going to try to come back. Sometimes we use drug-coated balloons to try to prevent that narrowing from coming back so fast. But if we can get away with it, several of us will try to use a drug-coated balloon and try to see how much time do we get. If on the table we can't get a good expansion, that's when we put a stent typically. Or if you have a complete blockage, and a lot of times when you have a complete blockage, when you try to go through that concrete, you're not always in the middle of the vessel because there's no middle of the vessel to find. We'll be going through the side of it. And in those scenarios, a lot of times a stent will give you a better chance of staying open. So you may need a stent, but it's hard to know just based off one blockage or a description of a blockage, do you need one? Sometimes stent gives you the longest patency. The best long-term patency you can get is if you're healthy enough to get a native vein bypass for a long occlusion. You have to have a normal vein, superficial vein. You have to have a good surgeon. You have to be healthy enough for surgery. You have to recover from the surgery. And those are all possibilities. And, age is not always a limiting factor. It could be many other scenarios.
Yeah. And Marcia wants to add a note in there. Marcia, go ahead and unmute.
Oh, I was just going to say, Heinz was asking about the collaterals. Well, we know I'm 100% blocked again, even with a full metal jacket, so to speak. But my ABI reflects that I have good blood, well, decent blood flow to my foot. So that has to be from the collaterals, right?
Oh yeah, if your full metal jacket was down and your leg is still on, that means you have collaterals.
Right.
If you didn't have good collaterals when those went down, your leg would have been purple, blue, and cold and in the ER. So your collaterals keep you from completely becoming an emergency.
Right.
Yeah. And that's usually the profunda artery, the deep femoral artery, the one in the groin that we try to avoid messing with. Because when things go down, that's the artery that's your lifesaver.
Oh, okay.
So
Well, anyway,
And
thank you.
Go ahead.
Marie has a question. She wants to know what can be done to stop collaterals from blocking. Can collateral vessels get blocked? And what do you do to prevent them from blocking? If so,
Collaterals are a little tricky because they get big in where they start, but they taper down somewhere as you go down. There's nothing to really prevent that other than taking the medications that you would take to prevent any clotting. Collaterals typically don't all shut down unless there's a clotting problem or something else in a more rarer scenario. Typically your collaterals, as long as someone's not messing with those collaterals or blocking them with a covered stent, they shouldn't typically go down. Now, sometimes you can clot anything, and you have rare patients who have clotting problems or even the collaterals clot, and those are the ones that come in very acutely, very emergently to this type of scenario. So really, only the medications and doing everything you can to keep your moving if you can is the best things to do. Is different medications, getting good workup to make sure you don't have underlying, if it's already been done. And there's rare people that we've seen that we still can't figure it out. There could also be things called vasculitis, where some people have issues where their vessels get inflamed. A lot of women have that. Some of the Asian populations have that. There's different names for the different vasculitis. Smokers especially have a vasculitis called Berger's, where everything in the foot gets very small and wispy and nothing stays open.
and we have a question. We're jumping around a little bit, but this one is a concerning question that I have, and I'm going to give my opinion first because I have a very strong opinion. But you know me, I'm very opinionated.
What?
But
All right.
it's a question that's coming in from YouTube, from Tom, and he wants to know, in your opinion, he wants to know your opinion on axillary bifemoral bypasses. Have there been recent advancements? What's the expectancy of this to last? I have seen this rarely work. I have seen in every situation where I have gotten involved and gotten the patient a second and even third opinion, including one just this week, where the doctor said to the patient that this is the easiest thing to do. You've already had a cabbage. There, all these other procedures, doing an aorto bifemoral bypass, which usually is the kind of the step before. It's just going to be a lot bigger for you. The axillary bypass, it could last you 7 years. Well, they don't even go into the actual data, which shows a 30% mortality rate with it in even the first month. They don't exhaust all minimally invasive efforts. I had one person out here in California that literally ultimately was treated with a TPA, catheter delivery of clot busting drugs in the aorta. And the vascular surgeon says to me, "Oh no, yeah, we could do that, but it's not going to last very long. The axillary bifemoral bypass is going to last up to 7 years. So we're just going to try and work on kicking the can as far forward as we can." But what is the contingency plan? We tell every one of our patients, if you end up having to have a procedure, you always need to ask the doctor, you might be kicking the can forward, but what happens when that fails? And with the axillary bifemoral bypass, we've had too many experiences where it becomes life on the line at that point. There's nothing that a lot of these doctors can do, even with some of the advances in medicine and the durability for those, number one. And number two, we've had a cardiologist tell one of our patients that her heart is actually in jeopardy. Actually, two of our patients, another gentleman who's on the line here as well, that it actually ended up putting his heart and her heart in jeopardy. And then number three is it bypasses all of the major organs, the kidneys. And so if you don't open up the aorta, you're ending up, your kidneys and such are surviving off of these collaterals, is what I was told. I'm not an anatomy expert. I'm not a doctor, but I can only tell you that we have sent people for axillaries. They've been in literally life-threatening situations.
Yeah.
But they're the last of the last. Doctors will tell you, vascular surgeons, advanced vascular surgeons tell us it is palliative care. It's the Hail Mary of Hail Marys, last resort. And if it's possible, if there's any other option, take the other option. So that being said, I told you I'm opinionated. I'm happy to have you
Yeah.
share and even contradict me if you'd like, but I can only
No, I
go
mean,
by my experience.
I wouldn't contradict that in the sense of, I agree, everybody should ask why not another option. I got to be honest with all of you. It's not fair that you need to be asking these questions, but that's unfortunately the reality, is the limitations of somebody's abilities, experience, or politics, or whatever it is, shouldn't be your problem. But unfortunately, we live in a world where that is what you need, and you're lucky to have Kim providing the kind of options and telling you what to seek out. But I think about it this way: when my mom had cancer, the first question should be, how many opinions do we need? It should never be, okay, let's just trust the system. And I come from a country where you don't ask questions. In India, you basically sometimes don't even tell the family member they're sick because it messes with their mind, and they don't even want to tell them they have cancer. So we live in a different world where you have to seek out second, third, fourth opinions. Unfortunately, axon bypass is not great because it's a prosthetic man-made bypass graft going from your armpit to your groins. So it's not great no matter what you do. In an emergency trauma situation, sometimes when other options have been exhausted by capable people, whether it's a surgeon, a cardiologist, or an IR who does aortas and iliacs or talks together about it, then, if everybody crosses those bridges, I think, it is fine. That's a decision to take. You do get what we call retrograde flow through the bypass, or meaning that the blood flow comes down through the bypass to the groins, but it'll often go back up to a certain degree to certain areas. Now, whether it feeds the organs or not, it depends on how long that blockage in your aorta is. If your blockage in your aorta is below the kidneys, which many of them are, all the blood flow to the kidneys and your gut should be still maintained. The heart's a little different story, because patients who have coronary bypasses and stuff, that may be stealing some blood flow from the heart, because those bypasses take blood from your arteries by your shoulders. So that may be one of what the cardiologist is talking about. So does it cause immediate demise? No. The patency is not great, but if everything else has been exhausted by a team of people, then I think that's worth a conversation. If multiple people can come together and say, yes, I agree. The way that always interests me is patients, when they hear cancer, They're like, let's book a ticket to Mayo, Rochester. We'll go to that cold city. I don't care. But when we tell them that you're going to lose your leg, they don't want to come downtown Chicago from Indiana. So I think it's the understanding of all this and being willing to ask all the questions, asking what, why not, what else, who else. This is arterial cancer. There's no such thing. I've been using that term for like 7-10 years. There's no such thing as it, but I think it is kind of like that. We have to keep people in remission, and cancer free, arterial disease free if we can. That should be our goal. We have to kind of come up with the understanding for this for everybody. But I agree with Kim. That should never be the first step. If someone's offering you a long bypass like that, ask why not and who else can try.
And you bring up a good point about emergency situations, and that was actually with one of our patients where they came to us and said they want to do this axillary bifemoral bypass, and I said, "Is your aorta infected?" And they said, "Yes." And I said, "Get that bypass. We'll figure it out later, because once they treat and they're able to get the medications in there into the aorta, then they can always go back at that point, and then they can treat the aorta. So if that axillary does go down, they still actually do have the backup with the
Yeah.
aorta that they can go ahead and make sure that that's opened up and free flowing as well." But
The
second,
emergency
third opinions.
situation, absolutely, yeah.
Yeah, there's no doubt. Frank, go ahead and unmute. Ask your question of Dr. Kumar Madassery.
Hey, hello, doctor. How are you?
Good. How are you?
Good to see you.
Good
Thank
to see you,
you.
Frank. Yeah.
I've been a right leg amputee for 7 years.
I remember.
If I
Yeah.
should ever need another intervention, I do not believe I need one now. But is it possible for an amputee to receive any wires or treatment from the residual where the foot used to be?
Yeah, the
That's
only time we treat that, and we do it every now and then, is if you develop a wound on your stump. There are times where you have underlying arterial disease in the arteries that are left behind, your SFA, that we'll have to touch up. We do that every now and then. Sometimes people lose weight in their amputee leg, and then the prosthetic rubs, and then they form an ulcer that's not healing with wound care. Those are
What
some
a
of the patients that
coincidence.
we go in and we try to see. Now, the difficulty is that with an amputation, you don't have normal tapering of vessels into kind of recirculation. So if there's disease in the larger arteries leading up to the stump, then you can treat that. But sometimes if it's all the way down there and it's very small, there's not a lot more to improve. But then again, the problem may not be the blood flow. But you can have things done if you develop a wound. It's not necessarily good for pain. There are some plastic surgeons who do things like nerve transfers and things for amputation, that if it's a pain problem, they can work with that. There are special surgeons for that. But for wounds, that's definitely something I've treated amputees for.
Okay, thank you.
Welcome.
And Donna has a question. Donna, do you want to go ahead and unmute?
Hi, Donna.
You got to unmute to ask the question. There you go. I can see
There we
you're
go.
sitting there. Perfect.
Yeah. Thank you. Hi, Dr. Madassery. Hey, is there anything that we can do ourselves to try to slow the progression of the PAD?
Yes. Take all the risk factor medications, which is your statins, your Lipitors, keep your cholesterol well, get your glucose under control, stop smoking, walk as much as you can. If your kidneys are having issues, try to find out what can improve that. Keep your blood pressure in control. These are the risks. If you can adjust and optimize the risk factors of PAD, then you're going to slow the progression of it. So the biggest things usually for most of our patients in the population are diabetes and smoking. So if you're a smoker, it's very tough. Trust me, my dad smoked 50 years. I get it. But when you're facing losing limbs and fingers, that's sometimes a wake-up call, or you need to keep working with it. There's programs, there's medications. My dad tried hypnosis, water therapy. I mean, God knows what all. But smoking and diabetes are the two biggest ones. Next to that, it's going to be your cholesterol medications, your blood pressure, which again, all these things also cause strokes and heart attacks. So it's not just for your legs, it's for your heart, and your brain.
Great.
I
Thank
think
you.
Wouldn't you love a patient to come in and ask you that question? What can I do? How can I help, doc?
I know.
How
It's
can
usually
I make a difference?
it's usually what can you do for me without changing anything I'm doing?
Exactly. Exactly. So, Alan actually does have a question now about amputation. So go ahead, Alan, unmute and ask Dr. Madassery your question.
Hey, doc, I had the left amputated at Rush, and we had my, I had a synthetic bypass that lasted 14 years. It was above the knee, so it had a good landing zone, and it shut down shortly after that amputation. Now, is it true? Other doctors have told me this, but you know how I trust a few people.
Yeah,
Oh,
I'm aware.
is it right? Is that because there is no outflow or to the lower part of the limbs, which that feeds? Yes, that it is typical that shuts down in an amputee.
Yeah, so for any bypass or honestly any intervention to succeed, you need to have outflow. There's no use of having water coming to your faucet, but your faucet's off. You're not going to have water running. So if an amputation is done and that's providing a lot of the outflow for your bypass, there's a strong chance that all that resistance that your blood is getting in the bypass causes it to cause turbulence. So blood clots usually because of a couple things. It's like turbulence, something blocking it, causing the blood to kind of clump up together. So if the outflow is narrow or blocked, then it's going to catch up on itself and then it clots. So it's not unlikely that the amputation may have induced the reason for the bypass to go down.
Okay, and that's where the profunda picks up the excess work.
Correct. The profunda
Okay.
starts getting bigger and bigger and bigger, trying to provide these branches that come down, and kind of form blood flow to the tissues and the distal parts of the amputation.
Okay, thank you.
Yep, of course.
And Maria's going to challenge you here. She says, yeah, she used to smoke, but she has no diabetes. She has normal cholesterol, family history, has, what does this say? I can't read what it says, but, of PAD, but not to the extent of what she's experiencing. What else can she do, aside from that? I mean, exercise, food, diet. I mean, it is the best thing you can do in order to improve prognosis.
If it's the question is it with the smoking, did it cause pruning of all the vessels down low? If that's the case, then you keep trying to do exactly what everybody else is doing as much as tolerable, which is the medications, the diet, the walking, forcing yourself to push yourself. So, we got to be honest with ourselves. Sometimes there's not always a magical cure. The question is, what can we do to keep improving little by little to sustain the quality of life? Are there spine stimulators for the pain to help you move better? Some of those spine stimulators have been shown to cause the blood vessels to actually open up a little bit. There's some data on that. So I'm not sure if that's something that's been entertained, if it's a pain issue keeping you from being able to function. That doesn't work for everybody, and there's issues, but you have to kind of keep crossing things up the checklist of things that you can do or someone can help you with to help you do things more that you're doing. So it's a little tough to say what's going to be the magical cure without knowing what the images look like, knowing what the status is. But sometimes it's still trying to optimize all these things. And people say, how can I lose weight when I can't walk? It's a tough question. It's a fair question. It's still working on the diet, still working on whatever movement in a chair that you can accomplish with the little pedals under your chair. It's whatever, something more than current.
We always suggest getting with, a hematologist, getting with a dietitian, and pushing for more advanced blood work because there could also be some additional nutrient deficiencies. For my dad, it was an MTHFR mutation, which is not talked about as much, yet it's on the American Heart Association's website as something that should be looked into if you can't find any other explanation. It's a gene mutation that makes it a struggle for you to turn food into fuel. And so some of your vitamins are not absorbing as well as they should, leading to a particular enzyme known as homocysteine to elevate, and it's like nails on your artery wall. You have damage to your arteries, and that's going to trigger the inflammatory response. So that could be an issue. There could be genetic clotting disorders. There's so much more, right, Dr. Madassery, that can be looked into. And it's just up to you to advocate for yourself because, doctors don't always do this until you ask the right questions. You've got to advocate and make sure that you're getting the answers that you need.
There's studies going out. There's people doing beetroot juice studies for PAD. There's a lot of different things out there to try to see what else can help when nothing else is really, or is there some things that are natural that can help you? So go drink beetroot juice. It's not going to hurt you no matter what. There's instead of waiting
Chia
10 years.
seeds. So this one's interesting. You're going to love this, Dr. Madassery. So we had a patient that we're always talking about. I grind my chia seeds. I put it in everything because I know the health benefits of it. But one of my patients came to me and said her friend told her that if you're on blood pressure medications, you shouldn't be having any chia seeds. And so I went to one of our cardiologists and I said, so what's the deal with this? And he kind of laughed and he was like, actually, I shouldn't be telling you this, but if you eat a lot of chia seeds, it works so well that it interferes with blood pressure medication and insulin. So some of these natural means could actually make a difference. And so instead of just depending on pills, if you haven't been put on pills yet, start on some of these natural means. We even have Dr. Antizana, who's Nancy's doctor, who prescribes Salon Cinnamon capsules. And there are studies you can look at online because he says it not only it helps mainly lower the A1C for those who are type 2 diabetics, but he said that it also may have some impact as well on the LDLs in your body. And there are studies out there. Always check with your own doctor. Don't take any advice or information and act on it from here. Check with your own doctor. But it is something that's interesting that he's a vascular surgeon, said, hey, Salon Cinnamon. So I'm seeing more and more doctors looking for more natural means to assist patients in becoming better partners in their care.
Yeah, I try to tell everybody, let's not assume there's a magical treatment for this. We're playing catch up to 10, 15, 20 years of disease buildup. You didn't typically get a heart attack from one burger last week. You got it from a buildup of plaque. Same thing. You didn't get the leg attack from just, your sugar spiked yesterday. So we're combating something that's been building up for so long. Now is what can we do that's least invasive, that causes the least amount of damage and risk to you, but understanding that this is a long-term issue that's been there. You just didn't really know. That's kind of the hard part.
And we just have just a few more questions, and I know you need to get back to your patients there. We have a question coming in from Debbie, and Debbie wants to know, she has lung cancer and the doctor wants to do a bypass. I don't know the details, but she's wondering if she should go and get another opinion to see if there's another doctor with a more minimally invasive option versus putting her body through a bypass having lung cancer.
I would always say before you have a bypass or intervention, make sure you feel comfortable that you're given all the options, whoever's doing it. I mean, if I see a patient with a long blockage, I'll have that conversation about bypass, even though I don't do the bypass. I'll say, you can have a bypass, we can work you up, we can have you see the surgeon, but here's why or why not. This is a good idea or that's not a good idea. I would ask the question of, why is a bypass better in this scenario? Is it because you have a good vein and you have a long blockage that a one native vein bypass, which has great data, is the best solution? That's a fair assessment. But if you say, well, this, I would ask, why not an outpatient same day procedure if it's going to allow you to have your lung cancer treated better or move on or whatever's needed. I would just ask, why is a endovascular intervention not okay here? Because it is a lot more risk.
Yeah, a lot. And I say this over and over. I always, with any procedure, if you end up with a procedure, you always ask, what is the contingency plan? Everything fails. What is the contingency plan when it fails? And it leads me to Nancy's question, how long can a stent last, as, if we're doing everything that's possible to take care of ourselves? They all go down. They just do.
Yeah. So that's an interesting question. In the best world scenario, you should hope for 5 years at about 80% patency, 90% patency. But that's in a perfect trial-based study patient population who you know, we those of us who do trials, everything tends to be the perfect category patient. They follow up everything. Everything's great. Now, will you get 5 years out of every stent? Chances are maybe not, but with good surveillance, good medication management, you can catch things that are early before it shuts down and manage those with a small procedure and keep it going for long term rather than wait till it shuts down. Now you're having to drip the clot buster in the ICU. Now you're having to do all these things. So a stent can last 10 years with touch ups and intervention in between with good surveillance. Is that going to be for everybody? No. And that's reality. But again, once we touch you, we have to understand it's just a question of how long can we avoid touching you again. When you get a bypass in a perfect world, a great vein with a great surgeon with no infection, no problems, will give you 10 years at 75% patency. Is that everybody? No, I have several patients I've had to reopen the bypass, the native arteries, ask for another, but none of these are great, but close surveillance, medication management, not smoking. We have a lot of patients who say, I stopped smoking. They get a stent, and then 3 months later they're smoking again because they feel better. They can walk to the drugstore to get their cigarettes now. It's like this is gonna backtrack now, and we're gonna, a lot of surgeons won't do a surgery or a procedure when you're still smoking. That's the reality. So we all have to play an equal part in this. A stent can last many years with surveillance, sometimes with a touch-up.
Okay.
Yeah,
that's
one
good.
of our patients.
Yeah.
Go ahead.
I said, that's good to know. Gives me some hope. And I'm just going to keep fighting and keep doing everything I'm doing.
Yeah,
You
the
know?
stents also are rely on how good the rest of your vessels are below the stent. If you have disease below the stents or even bypasses won't stay open as long. So it depends on what's healthy inflow, outflow. That's what matters most.
I'm told
We
I have
see a
a
lot of,
good pulse
that's
in both.
good.
Yeah. Yeah. And
We
they,
have so many bypasses that end up going down, and come to find out, the doctor puts in the bypass. Typically, it's a fempop bypass, and or a femtib, and the tibials are diseased, and they don't bother to check the tibials. They just put a band-aid on the problem, and it doesn't last very long. And I have them going down within weeks. And then I say, well, did you ask them how your vessels below the bypass look? Before they go back in, before they say, oh yeah, we got to redo the bypass, it's like, wait, hold on 1 second. Why did it go down in the first place? And can you have them check the health of the arteries below that to make sure they can support them when the top faucet's turned on? And almost every time we've said this, they've had poor tibial vessels, and we've had to send them to another doctor who's able to open up those tibial vessels to better support bypass.
Yeah, I
Yeah.
will say, hopefully that's not the common scenario. Most of the ones that you want to work with are checking those things or asking you to let them know how the tibials are. That's
Yeah.
a good scenario. Unfortunately, what we see is honestly, there's bad endovascular and bad surgical procedures everywhere. And it's not one or the other. It's unfortunately rampant because it's not well monitored, it's not well regulated. And, at the end of the day, patients have to be their best advocate, which you feel like that shouldn't be the case. But I will tell you, that is the
Yeah.
case. If I get sick, I'm going to demand to find out who's doing what and what the rates are, like in terms of success, outcomes, word of mouth.
Yeah.
That's just reality. In Europe, it's different. They don't have a money-based system, but then you might have to wait 8 months to be seen. There's ups and downs to every part of this.
Yeah. And you don't have as many options. And
Yeah.
it's tough to get second opinions with different options over
I
there
would say
as
that
well.
here you can at least demand a second opinion. No one should ever say no to that.
Nope.
That's almost illegal to say you cannot have an opinion, second opinion, sorry.
Nope, it's true. So Marcia has one more question, and then I'm just going to ask you my final question, which is taking us full circle back to the
Sure.
DVA. So
Sure.
Marcia, go ahead and ask Dr. Kumar Madassery your question.
Okay, thank you so much. I told you I had a full metal jacket and I'm blocked all the way from scar tissue, I guess.
Mm,
And I haven't seen my doctor in, it's been over 6 months because I was waiting for Medicare to kick in.
okay.
But so I go and get my scans, ABIs, and what else, blood work and everything. And then I see him next week. So, and I'm walking a lot, and I don't smoke anymore. and my diet's like 99% good. It isn't perfect, but my question for you is, so I walk a lot with pain, but like, what are some informed or education, or I don't know what, intelligent questions that I should be asking him? Like, we know well, I mean, I'm getting an ABI, but we know I'm blocked up. It's how much blood flow, I guess, I'm having.
Well, what I would start with is how are you doing every day? Like, how's your life going? Because honestly, if it's blocked and you're walking to your doctor's office, you're doing better than many. So the question
I'm
is, what
hiking. I'm hiking. I mean, I'm doing
if
good.
you're doing better than I am without a stent. But what I would say is, what is the reason to have to do something right now? I would tell you, if you're blocked and you're hiking, I personally wouldn't try to touch you unless you, God forbid, developed a wound somewhere, or
Oh,
you're having
he
pain.
isn't. He's not
Okay.
planning on it.
Okay.
I think it's
Okay.
just he's keeping
I
me
see.
monitored, but I'm going
What
to
I-
have consultation with them. So I don't know, is there something I should be asking or
You
looking
can,
at?
yeah,
Or
you can ask, say, hey, if I develop something that needs something, what can I do? Are we going to try to reopen this? Do I have a good vein for a bypass? Am I a candidate for a bypass? How does the rest of my vessels look below my legs? Has my ABI gotten better? Where am I? I think those are the things, is what's my next step if something does change in my symptoms?
well, he already
Uh,
said bypass, but I
oh,
went to a
alright.
vascular. I went to a vascular doctor, and he said, because I have such good blood flow from collaterals, he said you don't need it.
Yeah, I mean, you can open up even old occluded stents now. Is that a best option? That's a little hard to tell. If you're high risk for surgery, if you were, then I'd say you can always open up something, most likely. If you have occluded bare metal stents, they don't stay open that long once you try to reopen all that stuff that's been chronic for a long time. Covered stents are a little bit easier to open, but then again, they go down hard. So there's nuances to all of it.
He
If
said
if you
that I keep scarring. He said, so you're just going to scar again. Do you think
Yeah,
that's right?
I think what he's
Because you're
saying,
so
or
young.
the term he's trying to say, is it's what we call hyperplasia, is that if you have bare metal stents, when your body reacts to all the work you've done in there, all touching the vessel, it creates inflammation, and that inflammation lays down all this tissue. That's the scar he's talking about. It's called hyperplasia. So that drug-coated balloon, it tries to fight the hyperplasia. The drug-coated stents, they try to fight the development of that tissue laying down. So that scar tissue is sometimes, it's inevitable. Question is, how long does it stay away from growing, and how long does it stay away from causing a blockage or bigger problems?
3
Right.
months.
So that's the scar, is the hyperplasia, is what he's
Thank you.
referring to. Yeah.
Thank you.
And I'm so sorry, Dr. Madassery, one
Yeah.
more question just came in.
course.
Denise, do you want to jump in really quick with your question? You have to go ahead and unmute. Here, let me try and help her. There we go. Denise, go ahead and unmute.
There it goes. Sorry, I kept hitting it and it wouldn't.
That's
Okay.
okay. Good to hear
I'll
your
make
voice.
this as quick as I can. Sorry.
Sure.
I am very newly diagnosed. I haven't even been to the vascular doctor. I'm waiting to get in. I'm just like in freak out stage at this point. But here's my question. So I have a lot of trouble walking. I have for 12 years. I've had 2 back surgeries because they said all of that, my hip to my leg pain, is all related to my back. Neither surgery corrected that. If it's possible that this is related to a blockage, could I have had this for 12 years and nobody figured it out?
Yeah, the problem with PAD, and why a lot of people go unnoticed and untreated, because some of the symptoms are mimicked by other problems. Arthritis is one of them. Arthritis, back problems, sciatica of
I
the
have
nerve.
all.
Yeah, those often have similar symptoms to arterial disease, which is why a lot of people ignore it themselves. They're like, I'm just getting old. I was a football player. I worked, in a factory. I did this, I did that. This is my hips. I got water in my knees. So a lot of patients and physicians think this is aging. You do have you obviously do have arthritis and back problems, whatever. So they
Yes.
try to address that. Whereas you may have had blockages in your for those kind of symptoms you're describing, we're talking about things above your groin. So in your aorta or your iliac arteries, if you have problems there, that's when you tend to get those kind of symptoms. So the answer is yes, you could have had underlying PAD, but because many people as they get older also have all these other problems, the PAD is often underlooked until there's something that you see. Like if you think about ovarian cancer and pancreatic cancer, most patients don't know they've had it until it's too late because your body doesn't show symptoms until it's spread.
Okay.
Similarly here, if you don't have other reasons to suspect PAD, it is a long time ago or many recently years ago, people didn't look into it because they're like, you have all these other things that we know for sure.
Okay.
That's an unfortunate thing. So
I was
yes,
just curious how 12 years has passed and
We see
maybe
it all
this
the
has been
time.
my issue all the time, all along, and how
we
Yeah.
it
yeah.
scares me that it's gone on this long and not been treated.
Well, the good news is you're getting diagnosed now and you can still do something about it. We talked in the beginning about walking is medicine. It's not just about walking though. You need to learn how to walk effectively to grow those collateral vessels. And the time in which you're able to actually grow most of those collateral vessels is when you are pushing through the pain. And that's when your body is triggering the collateral network to kick into gear and start rerouting that blood flow. So we don't care how long you're walking or how far you're walking. What we care about is from the moment that you start feeling that pain, how far are you walking and pushing through that without slowing down to the point that you're almost limping and you need to stop and rest, get some relief, and then you do it again. That's what we care about, because that claudication time, if you're working it, like you go to the gym, you're always pushing past that one last rep. You're working with a trainer, you're doing these bicep curls, and you say, I can't do any more. And you're halfway up, and he's like, just one more, give me one more, go. I can't. Oh, yeah. I did it. Right. That's the moment that you start building the new muscle and things like that. It's the same thing when you're walking. You need to walk like you would be doing those bicep curls in order to get those collateral vessels to grow effectively.
Okay. I mean, I'm trying. I started walking. I haven't walked for
Good for
12
you.
years for this reason. And I'm trying to walk through it. I'm not getting, I don't think I'm getting very far, but I guess something's better than nothing.
Nope.
And that's
It
what I have
is.
to
And
live
we
with.
even have a walking program. So if you go ahead and message me afterwards, I can get you a text-based program that we have that helps you to measure your claudication time and to improve that claudication time is what we call it. And we can
That would
walk
be
you through
great.
that process. No,
Thank you. That
definitely.
would be
Because
great.
it's nice when you can actually see that progress that you might not see otherwise, every single day.
Okay. Thank you very much. Thank you both.
You're welcome. Sorry, I didn't mean to jump in. It's my soapbox. The walking is medicine.
That's
Very
okay.
true. Very true.
So I want to go full circle back to the DVA because I think it's really important. It's one of the most advanced options that's available right now, the Hail Mary of all Hail Marys. So, would you mind just talking again? What is a DVA? What are the indications for a DVA? How do you talk to your doctor about it? And what is the process by which, it effectively improves the circulation, how
Mhm.
long it lasts, and that kind of thing. It doesn't last very long. So my whole point there is it's supposed to just get enough blood flow to heal the wound and get you back on your feet to walk, right?
Yeah, so DVA, we reserve it as currently I call it the nuclear option, meaning that you truly, by an expert, can be told that you don't have any normal arteries in your foot to connect anything to, whether by surgery or from the fancy wires, tools, access points that any of us on the complex level do. We call that a desert foot. And a lot of people with diabetes, kidney failure, and smoking have what we call a desert foot, meaning your arteries above your knee in your knee can all be sort of okay, but then when you get to the ankle and foot, it kind of becomes wispy little straws and it's kind of like a desert. So in those patients, there's no magical cure for blood flow. And if you have a wound in your toe, in your front of your foot, nothing we do from a vascular standpoint up till DVA could we do anything. So your only option was truly let's say I did the angiogram and I say you have a desert foot 10 years ago, your only option is a major amputation when it's needed. Over the years now, several of us around the world, from the inside, like an angiogram, we go down your leg into your arteries below your knee, and wherever typically one of the vessels will jump across into the vein next door. And we direct the blood flow to the vein, which typically is supposed to bring blood back to your heart. Instead, in that one vein, will force blood down your leg. That's a little unnatural for your body. But what we've seen that happens is if that path that we create stays open, after about 6-8 weeks, your foot starts opening up either arteries that have been asleep, small ones, or it starts helping form new blood vessels. So that's what's called a DVA, deep vein arterialization. So we're making a vein try to act like an artery that's within your own body. Now, there's a lot of unknowns. Those of us who've done it, I've been doing it for about 5 years now. There's things that we learn all the time. And luckily, we have a network of people around the world that we learn from each other. We've adapted. Our data and the best data we have says if you're a candidate for it and you have a stable wound, about 60 to 70% of patients that have a DVA can save their foot to walk, meaning at least only to a TMA, which is a transmet amputation. So just all your toes are gone, but you can still walk on a healed TMA. 60 to 70% limb salvage rate. Now, within that population, that we found that patients on end-stage on renal failure, on dialysis, they unfortunately have slightly lower success rates, but it's not zero. So my answer is, if we have a stable wound and you truly have a desert foot, even if it's 50% is better than 0%. If you're willing to take that journey, it's not a magical bullet. When I do these cases, I talk to the patient, their families. I say, this is going to be a little bit of long-term management. I need to know who's doing your wound care. If it's not me or one of my people, I need to talk to them, because you can have swelling. You can have early infection. Your wound can look a little nasty in the first few weeks, and you have to have a podiatrist, someone who knows what they're doing, to say, we can watch it right now. If they have to have a surgery after the DVA too early, they need to be able to do what's called an open amputation to allow your tissues to continue perfusing before they try to close it down the road. So it's not a quick magical bullet, but if you're at the point of a major amputation, if you have the potential to walk, if your wound is stable, and you are willing to go through a journey to save your leg, then I offer it. So there's a lot of nuances to this. I have a patient that's 5 years out. His DVA is down, and that's okay. We've found that if the DVA shuts down after that 2-month mark, the process has already started where it's okay that it's down. That's what we're finding out. So he's 5 years out and he still has a foot that's got an amputation that's healed, but his DVA has been down doesn't matter to me, because your wound healed and you're not in rest pain. So there's a lot of nuances, and only a few of us out there are doing a lot of them, but you can ask that question. And if you can't get an answer, Google, because a lot of us I get patients from internet searches, from being part of trials. You can search these things, ask people, ask Kim.
Yep,
Who are
we
the
have
people
all the
that
names.
who are the people
We
that
know
have
who's
done
doing
these?
them.
There's a circle of people, of all of us, who talk to each other and can
Yeah.
help find someone sometimes, who maybe we know how many they've done. There's not a lot of people that have done a ton, but we're all trying to educate each other and teach people. The problem a lot of people won't do it is, it takes a lot of procedure time. It takes a lot of costly equipment. So unfortunately, we live in a world where people live on an economic basis. And so they may not offer it or do it. Now, that's when you got to say, why can't this be an option? And can you send me to someone who can do it?
And that's really important. And so if you go to padhelp.org or call our Leg Saver hotline at 415-320-7138, we can help you find a doctor that can consider, at least review your case and see if this might be an option for you. And so, yeah, I tap into Dr. Madassery all the time. Hey, do you know someone here? Do you know someone there? Who would you trust your leg with?
It's kind of like high school. It is a close-knit network of a lot of us. So we do have friends around the country that we would at least say, hey, do you know somebody in this area that we trust regionally? So it's not always possible, but people like Kim are a great resource to connect. It's like a network when you think about like Minority Report or, something like that, like Google. Kim's our Google.
Yeah, especially for VAD. I do have doctors that call me and say, "Hey, do you know?" But one thing I think that you brought up in terms of the DVA really quick was really important, that I love that you have that real tough conversation with them, because it's not for the weak. It's a real journey. It gets worse before it gets better. And there's a lot of pain associated with it. There have been a couple, we've had many a nights up in the middle of the night trying to walk them through, and you just got to give them hope and say, but you're keeping your leg, you're going to get through this. You will get through.
Yeah,
And so
I
it's a
I
lot.
have an honest conversation. It's not my body, but I tell them there's nothing wrong with an amputation if that's what you want. It's your body. Many people can do okay with an amputation provided recovery goes fine, provided they can get a prosthetic. There's a lot of caveats, but doing something that's on the newer edge also has a lot of caveats. So
Yeah.
I tell them, if you don't want to go through all this, you got to be okay with this, and the family has to be okay with it. To say I'm okay with that, that's a personal choice. We want to do these things for patients, say no, absolutely not. And even if it ends up in that, at least I know I tried everything. That's what I tell them they have to be okay with.
I appreciate that. Dr. Madassery, we really appreciate your time, and thank you so
course.
much for doing everything you can to save those piggies, to save life and limb, exhausting all efforts, and being one of those doctors that never rests on your laurels, that is constantly learning and growing and trying new things to try and improve care for your patients. So thank you so much.
No, sincerely appreciate it. I hope all of you can feel better and get some solace in whatever you're doing, but reach out. Kim's a great source, and just understand that you're not alone.